So, good afternoon, everybody. My name is Deirdre Dunn. I work in health and wellbeing, and I'm part of the Southeast Community Healthcare Menopause Awareness Working Group. You're very welcome to our fourth Menopause Awareness webinar, and as I say, organised by the Southeast Community Healthcare Working Group. And today's session actually coincides with World Menopause Awareness Day. Today is the 18th of October. So today's webinar is entitled The Physical Aspects of Menopause and Perimenopause. And our presenter today is Shirley Trimble, and we're absolutely delighted to have Shirley. Shirley's 30 years qualified, and for the past 10 to 15 years, she has had a special interest in women's health. So I know we're in for a treat today and have lots of questions answered, Shirley. So I'm going to hand over to you now, and thanks very much for joining us today.
Thanks, Deirdre. Delighted to be here and super to be part as the final and fourth in an episode of managing the menopause. I work as a chartered physiotherapist in St. Luke's Hospital currently at the moment, and I'm straddled between the maternity services and the gynae services. So as part of my role in the gynae services of treatment of women with pelvic health conditions, the main cohort of my patients is aged between 35 and 60, probably even tighter between 40 and 55, I suppose, too. So I have a lot of experience with women who are going through the menopause and the perimenopause. So delighted to talk to today. So what am I going to cover today? First of all, I'm delighted to have the anonymity of the questions that Deirdre was talking about at the beginning. I think certainly the second part of my talk will be to do with pelvic floor, and some of those particular issues and questions that people may have can be of an intimate nature and can be embarrassing for some people. So I would welcome the questions if you can put them in, even for yourselves, and if you think that they might help somebody else in the group or whoever might be listening or listening onto the recording, it would be great. So what am I going to cover today? How the menopause affects females and males in our company and the greater society in general. What is menopause? Again, I know I'm number 4 in a talk, but for anybody who is just signing on today to talk, this might be their first tiptoe or introduction into menopause. We'll just do a brief description of what it is. The physical and the musculoskeletal considerations. Musculoskeletal means muscle and skeleton together, so that's my bread and butter. Pelvic floor consideration. So anything about, we talk about the bits below the waist. There'll be a good bit of discussion about that towards the second part of the presentation. And I want to give you some signposts and a take-home message. I want everyone to have taken something from this talk. Anybody that knows me knows that I love to have try and have a practical solution or something easy and recreatable that you can put into your toolkit to manage your symptoms. I want to arm you with the confidence to know that what you may be doing is right, and also yourself personally and those around you, be it your sisters, be it your work colleagues, be it some of your patients. And I'm talking to HSE staff here, so I may be talking to some clinicians as well, and give you the confidence to manage them well. So the impact of the menopause on women and greater society in general. The average age of the menopause is 51. These are just some stark facts. One in 3 of the UK workforce are over the age of 50. Now that's a 2022 statistic. Over 500,000, more than 500,000 women in the workforce in the Republic of Ireland are aged between 45 and 64. So they are an important part of the workforce in Ireland. That's from the 2016 census. I don't have the recent results. 56% of women over the age of 50 are in the workforce in Northern Ireland. And then menopause is rarely talked about in the workforce. So that's why it's lovely to be involved in this as a workplace initiative. Women are of huge societal importance. We've seen that from the statistics above. They're a valuable commodity, and it's really important that we look after them. They're important as individuals, and also sometimes known as a sandwich generation, where you can be, as a 45 to 50-year-old woman, be caught sometimes with caring for those that are older than you and also caring for those that are younger for you. They have a really important familial role, really important in the workforce, in their local community, and it's important that we look after women who are going through the menopause at home, work and play. Just to give you an example from a staffing point of view, I was doing a talk last year for the statistics for the staff of St. Luke's Hospital, which would be one of the larger employees in the Carlow-Kilkenny area. There was 1,551 staff employed in St. Luke's Hospital last October 2022. 1,182 of these are female, so that's 76%. Of this, 76% of the 1,182, 408 are over the age of 50. So this does fall in nicely with those UK statistics and the Northern Ireland statistics too. And 777 of them are in the workforce, are less, of the women are under aged 50. Just a point of note. I think the important thing to remember as well when we talk about the age of the menopause is that our life expectancy has changed. Back in 1850, 70 years ago, the average age of the menopause was 45. But look at the life expectancy, it was also 45. Women weren't expected to live past the age of 45. And with various advancements, if we fast forward to 70 years later, in 2020, the average age of the menopause is 51. Our life expectancy now is 82. So that's an extra 32 years added on. Around 30% of our life now is postmenopausal. So that's really interesting to know as well. And it's not about the length of that, but it's the quality of those years as well that we want to try and engage in evidence-based advice that will give us an ability to enjoy those years as well. The Menopause Hub survey, just another little facts and figures. It's an Irish survey that was done by the Menopause Hub in conjunction with IBEC in 2021. It's a really interesting bit of timely information with regard to menopause in the workplace for information. I won't go through this, but it's, if you want to reference it yourself, you can. They've also just in 2023, recently, hot off the press, done another survey where they surveyed 2,892 women aged between 35 and 64, and this was conducted just last month. Some of the findings in that were 72% of women said greater menopause awareness training for staff at their organisations was needed. So we're ticking that box here, which is great. A really important point to note was, and I'll be talking about this later on, of those surveyed, of these women aged between 35 and 64, 51% of women in long-term relationships acknowledged that those relationships were suffering. I think that's hugely important. And also, the final bit that I took from the survey, again last month, of the supports made available, the three most popular supports identified by women in these age were free health checks for over the 40s, free HRT, hormonal replacement therapy, and more menopause training for GPs. So three things were taken from the recent IBEC study. So the statistics of the menopause, I love a few facts and figures. It's important to know that not everyone will suffer through the menopause. The research says that 75% of women going through the menopause will have symptoms. So remember, 1 in 4 won't have symptoms. Of those 75% women that have symptoms, a third will be classified as mild, a third will be classified as moderate, and a third will be classified as severe. So what is the menopause? Briefly, it's a transitional phase closely linked to your hormones. It's generally not sudden, it's transitional. You don't tend to fall off a cliff and hit the menopause full on. Some people report it like falling off a cliff, but generally it's not. The menopause really is the anniversary of the year after the date of your last menstrual period. The store of eggs in our ovaries is depleting. Our ovaries produce eggs and they produce the three main hormones, estrogen, progesterone, and testosterone. And as a result of this decrease in storage of eggs, we also get a decrease in this hormone productivity. So we're really talking about living the rest of our lives in the postmenopausal age with reducing levels of estrogen. We don't ever fully stop producing estrogen, but we taper off and reduce. The perimenopause as well is talked about. So the menopause is really just one day in your life. And the perimenopause, peri means around the time of the menopause. And if you think about menopause, MP for short in the top, think about meno standing for menses or menstruation and pause meaning stop. So it's a ceasing or a stopping of the menstrual cycle. Also important, and I won't be covering it today, but there are many women that don't go, there are a number of women that don't go through the menopause for their own gynecological reasons, for their own biological reasons, and it's important to note that too. And also from a surgical point of view, some people who have had surgery, previous surgery, will either go through an accelerated early menopause or won't go through the traditional menopause. This is a nice infograph with regarding to estrogen levels in our bodies. If you look at the age profile along the front, age 12 to 34, generally our years of puberty and childbearing ages, if we are in childbearing, if we're able to to have the capacity to give birth to children. Estrogen levels going up the left-hand side of the graph and in green. Nice and steady, really, up until the age of the mid-30s. Then we start to see, we've seen there's various graphs that will demonstrate this, a slight dropping, really from the age of 35. And they talk about 35 sometimes being a magical, an unusual year because a lot of changes may start to happen around the age of 35. Then you see as we go into stage 2, which is the yellow, you'll see a dropping of estrogen levels. And I think it then ties in nicely around the age stage 3 of the menopause, what we know it happens around 51, of a tapering down. And then the postmenopausal age, which I think is important to embrace and to keep it positive as well. A lot of women talk about the postmenopausal phase being some of the best years of their life as well. So not to be all doom and gloom with it. So some of the impacts that can happen physically and some of the general symptoms, there are a myriad of general symptoms, but if we're talking about estrogen specifically, we know that estrogen is very protective. We know that it's neuroprotective, so it will help the brain and the nervous system. We know that it has an osteoprotective, a bone protection job. We also know it really helps to protect from a cardioprotective point of view, so for our heart and our blood system. The soft tissues, I'll be talking about that. That's my bread and butter. That's muscles, tendons, collagen, ligaments as well. Blood vessels I've mentioned above that the estrogen and progesterone help with the smooth muscle lining of the blood vessels and the bits below the waist in the pelvic area as well. And I'll talk in more detail about those shortly. Some of the symptoms, and there's, as I said, there's a myriad of symptoms, can be hot flashes, that can be weight gain. I was listening to a talk by one of the menopause specialists from one of the NWIP hubs in Dublin, from Holles Street, and she spoke about the average weight gain during the menopausal years is 2 stone. There is a propensity for menopausal women to have an increase in cortisol production as well during their menopausal years, and that can lead to increase adipose tissue or fat tissue around the middle, around the midriff. Brain fog, mood changes, migraine, headaches, sleep disturbances. If you have a sleep disturbance with anything, we know that it's been used as a form of torture in the past in some of the concentration camps. So sleep disturbances are common with menopause, and if we can help to manage that, that can be a game changer for some people. Skin and nail changes, there's a reduction in bone mass as well. These are just some of the symptoms, of the physical symptoms. Here we have a nice infographic that shows the different areas that estrogen can have an effect. I won't go through them all because there is loads of them, but you can see the importance of estrogen. We can't talk about estrogen without talking about progesterone and testosterone. They're the two other strong hormones that are involved in the menopausal talk. Progesterone, the hint is in the name, pro-gestation. It's positive for gestation. It prepares the endometrium, which is the lining of the womb, for the potential of a pregnancy after ovulation. It triggers the lining to accept the egg, and it stops the uterus contracting to reject the egg as well. It also influences the smooth muscle in the body, and that's really important for some of the tips I'll be giving you today. It works to balance estrogen. They work really together, progesterone and estrogen, quite closely. I've heard estrogen being described as the fertilizer on your lawn and progesterone being described as the lawnmower, that they work closely and need to work together. It's important for mood and sleep, and it starts to taper off at perimenopause. Testosterone, we know that it's produced in female bodies as well as in male bodies. Generally, women's bodies produce around between a tenth and a 20th of the amount of testosterone as in male bodies. Testosterone is involved in musculoskeletal health. It's involved in breast health, fertility, libido. This is another really important one. Is it the man or is it the hormones? Is it him or is it the hormones? It's involved with menstrual health, vulvovaginal health, and brain health. It's key for cognitive function as well, for keeping our brains sharp and focused. Time for me to take a sip of water. So to go on to the muscles and the musculoskeletal specifics, we have two types of muscle in our bodies, smooth and striated. Smooth muscle happens naturally. Smooth muscle is in our cardiac system, in our nervous system, in our bone system, and in our digestive system. Striated muscle is another type of muscle that we can actually actively voluntarily contract. So my biceps is a striated muscle. The muscles in my shoulder, in my glutes, which are my hips, in my pelvic floor and my feet are generally striated. Collagen as well is an important factor for menopause. For a long time, estrogen has been known as a regulating factor of the metabolism in many connective tissues like bone, muscle and cartilage. Estrogen improves muscle mass and strength. It also increases the collagen content of connective tissues. It decreases the stiffness of tendons and ligaments. That's a really interesting study that all of my reference points that I put into this, if you wanted to go into them in any more detail, are all referenced at the end. So tendons love estrogen, and a tendon attaches your muscle onto the bone. Tendinopathy. Tendons are thick bundles of muscle containing a large makeup of collagen. The menopausal transition period appears to be a turning point for the prevalence of some tendon-related injuries, such as carpal tunnel syndrome. You'll heard of that. You'll have heard of that. It's in the wrist. Some things like Achilles tendinopathies. Your Achilles tendon is down at your heel. Posterior tibial tendon injuries as well. There's been quite a bit of research done in 2018 with regard to tendon injuries. So if you're having, I suppose what I'm trying to say is, if you're noticing you're having any musculoskeletal injuries around the age of the menopause, that there may be a reason from a hormonal point of view that it's happening if there hasn't been a history of injury. A really interesting study that was done last year, 2021, that with regard to carpal tunnel syndrome, which is common during pregnancy, but it's signified by pain or heat or numbness into the fingers, particular fingers in the hand, after bilateral removal of the ovaries, and a really interesting cohort study, again referenced at the end. The LEAP trial, if we're talking about the hips, again, I don't need to go into detail. It's something that's really nice for you to look into if you want to. The British Medical Journal did a study on the treatment of women with hip pain aged between in the menopausal and perimenopausal ages. And the large study of women, they were separated into 3 treatment groups. One with a program of exercises and self-management. One group had a steroid injection, one single steroid injection, and one other group had a wait and see approach. And the exercise based, because I'm going to be talking about exercise being a physio, the exercise and self management group of these women that were diagnosed with hip pain, known as trochanteric bursitis or gluteal tendinopathy, they did much better in the study. So exercise is key. Joint pain in menopause. Watt in 2018 said that women are approximately twice as likely to have joint pain and stiffness around the time or after menopause than their perimenopausal counterparts. Cartilage, this is the shock absorber between the bones in the joints as well, that there's an influence on the cartilage at the time of menopause too. Menopause and muscles. A decline in our estrogen results in a decrease in muscle mass and strength of up to 10%. Really, really important then to try and counteract this with exercise. This may explain why women start to develop more muscular injuries, aches and pains as they approach menopause. Again, we're talking about the physical aspects of menopause here. These changes affect all the skeletal muscles, including the pelvic floor, which we'll be talking about shortly. Again, 2 really nice reference points to, I suppose, justify the existence of exercise programs, of which we'll talk about specifics in a couple of slides. One to manage depression, anxiety, and distress, and one about the importance of strength training, because strength training is really important for perimenopausal women too. This is really, really nice infograph on the guidelines of physical activity for adults and older adults and physical activity for disabled adults. Again, I won't go into the details of all of them. Reference them as well. They're really, really nice pieces of reference from the UK Chief Medical Officer's activity guidelines. If we just deal with the left-hand side, it goes nicely in conjunction with menopausal and perimenopausal women. The guidelines are at least 150 minutes of moderate exercise a week. This is weekly, or at least 75 minutes of vigorous intensity. Moderate activity, what is that? That is activity that causes you to increase your heart rate and increasing your breathing rate. So 150 minutes, that breaks down to 30 minutes of moderate exercise 5 times a day. You should be able to speak and have a conversation with somebody, but you shouldn't be able to sing. That's what they talk about, the moderate exercise. It's also really important to build strength on at least 2 days a week. So to do some form of strength training involving the upper limbs, the arms and the legs. Minimize sedentary time and also improve balance. Those are nice key messages to take home from this talk today. If you've learned anything from it, take that message. Health benefits in maintaining muscle mass. We know that it's good for a healthy heart. There's been a couple of studies that have been connected with hot flashes and exercise as well. We also know that it reduces the incidence. So if you have strong hip musculature and strong thighs, that can be show a reduction in urinary incontinence. And urinary incontinence is the involuntary leaking of urine. It also, healthy muscle mass also helps with diabetic regulation as well. Exercises and hot flashes, that's the reference point that I was talking about with regard to a study that was performed with hot flashes. So what's the answer? I suppose with regard to exercise, we know I've just given you a brief indication of what it affects from a muscular point of view. The ideal prescription for exercise would be this moderate intensity exercise, 150 minutes a week, or vigorous intensity, 75 minutes a week. Strength training at least 2 times a week and some balance exercises thrown in. So it's important from a lifestyle point of view when we're going through the menopause to take exercise seriously. It can be a huge assistance in terms of your management of menopause. What people sometimes say to me, what will I do? I suppose start where you are. That's the message. If you're a walker, aim to do a bit more. Aim to make that 150 minutes of regular exercise, 150 minutes of moderate exercise weekly. It's really important, we've shown in that previous infograph, as a stress management tool. It can also help your sleep. We know insomnia and sleep disturbances can be a part of some of the symptoms of menopause. So to use exercise to tire yourself to sleep is really important. It can help your thermoregulation. I think it's important to look at your barriers to exercise as well. Is exercise something that you've never done? Is it something that you need accountability to do? Would it make it easier if you were to meet somebody, to organize to meet someone? Should you move into the class setting of a specific exercise group which would target all those menopause markers? If you're a walker, vary it. Strength training, really important. We've talked about flexibility. Some restorative, I've a slide about yoga. Restorative exercise is important too. And this 150 minutes of moderate exercise. Bone health and menopause, estrogen, really, really important for bone health. And our bodies like a change of direction with regard to exercise. So if you are a walker, it's important, if you can, think about changing direction, going up and down cambers, and also alternating your direction as you're walking in terms of your stride too. What about yoga and Pilates? 2016, there was a study done with yoga and Pilates and the effects on menopause as well, and in terms of bone health. I think what we're looking at as a whole, and you'll have gathered, especially with talking to Aisling last week, the Cora registered dietitian, we're looking at a package of sleep, healthy sleep. Talking at nutrition. Nutrition isn't my area of expertise, but it's something that crosses over quite a lot with physio. Movement, exercise, and strength training is really non-negotiable. If you're able to exercise, you should be exercising during menopause. We also talk about embracing the anti-inflammatory. Estrogen, progesterone, and testosterone are all anti-inflammatory. Now, inflammation is something that's talked about in medicine, and we can take medicine as an anti-inflammatory. You've probably heard about it in that respect. But those hormones are anti-inflammatory, so if you can embrace an anti-inflammatory lifestyle through your food too, will help. Sleep, really important. A lack of sleep can affect your protein synthesis, which is really important for healing. Getting enough sleep, about 8 hours, is just as important as proper nutrition and hydration for preventing injuries and keeping bones strong. Diet. Aisling last week was talking about the Mediterranean style and the Indian style as well, which is interesting too. And what to eat. I talk a little bit about reducing caffeine with regard to bowel and bladder too. So we can't talk about the menopause without talking about HRT, hormone replacement therapy, or the rebranded version of it, which is called menopause hormonal treatment. I am not an expert in HRT, but it is one of the main, it can be one of the treatments for in conjunction with exercise and lifestyle that will assist you on your journey through menopause. The new term menopausal hormonal, treatment, not therapy. We're not replacing, we're actually assisting and adjuncting what is there. If you think back to the slide that I had about the tapering off of the estrogen levels, and that goes for progesterone and testosterone as well, we're augmenting what is there. And that can be a game changer for some people. Now, there was studies, I'm not going to get into it now, but there was a couple of studies that gave a close association with HRT and breast cancer. And there's a really, really useful link of a podcast on Science Weekly. It's the Guardian's podcast series about, and it's with Louise Newsom, and talking about the study that connected hormonal treatment and breast cancer, which has since been disproven. So for anybody that wants more information, it's a really, really useful podcast, Louise Newsom and the Guardian on Science Weekly. It's only, I think it's only about 2 or 3 weeks old, but it explains it really clearly. And this infograph on the left, because it links in with the breast cancer conversation and the fear factor of taking hormonal treatment as well, is a really nice one about the other potential risks that actually could be quite higher in our normal lifestyle that are associated with breast cancer too. Topical estrogen and the pelvic floor muscle training have been shown as a great partnership in the management of stress urinary incontinence. So I will talk about topical estrogen in a minute. Actually, while I'm here, I'll show you. This is when we're talking about estrogen. This is topical estrogen. You can have estrogen. You can have hormonal therapy subcutaneously through the skin. You can take it orally as a tablet, or you can take it locally in the vagina where it's inserted into the vagina. This is one I got from the pharmacy department in St. Luke's. And it's used, that's inserted into the vagina, and the click, and that releases your estrogen tablet into the vagina. I'll talk about that in a minute. But it's been proven with the NICE guidelines as a really useful tool for managing stress urinary incontinence. I think with MHT, it's really important to weigh up the risk benefit effect. That's really, really important. Get your information from a reliable source. Your GP that has an interest in menopause is your best bet. And modern non-oral hormonal treatment is generally seen as benign. That's really important to remember. So menopause and pelvic health. So we're talking about the GSM. You sometimes hear it referred to genitourinary symptoms of the menopause, also known as vaginal atrophy, which isn't a really very, I suppose, a nice term to be using, but the GSM is what we talk about. So we're talking about really the bits below the waist. If you have a look at this infograph in front of you, this is a slice of you down the middle from the side. From the left-hand side, you can see the pubic bone at the front, and at the back, you can see your sacrum. It's like an upside-down triangle leading up to the spine. In between these two bones, your pubic bone and your sacrum, is your pelvic floor across the bottom. Through the pelvic floor muscles goes, working from the sacrum, working from right to left, your back passage, so your anus, where your bowel matter comes out. Your rectum is above that. The middle, then, you'll see, is your vagina. And up above your vagina is your uterus or your womb, if you have one. Moving forwards, then you come to the urethra, where your urine comes out, and your bladder is above that. So you can see from this picture that everything is really in close contact with each other. Bladder, bowel, and womb. It's really, really nice, clear picture. I think it's really important that we understand the anatomy even before we have the conversation. This is even more important to understand as well. If you were standing, the vulva is any of the external genitalia on the female. If you were standing over a mirror with your legs apart and with a mirror down on the ground, this would be, and again, important that you know the terminology so that you can tell your doctor, your healthcare provider, if you think something is wrong. So working from the back, we have the back passage. Then if you move forwards, you come to the vaginal opening. Then move forwards again, your urethral opening, where your urine comes out. You have the labia minora and the labia majora, which are going around the outside of all of those. Your pelvic floor is supporting all of this as well, and your clitoris is towards the top. So really important that you know the names of these parts of your body so that you can be having the discussion and know what's normal and know what's abnormal. Because lots of things are common, but it doesn't mean that they're normal. And that's really important in female pelvic health. So the pelvic floor can take a hit during the menopause. Just trying to. Right. With reduced estrogen levels, all of the tissues of the areas that I've just talked about can become thinner and lose elasticity during the menopause due to this reduction of estrogen levels. They lose a bit of lubrication, sometimes a little bit of flexibility, and the bulk of the pelvic floor muscles can deplete. So really important that you know what normal is. So I would be recommending to anyone that they should know what their anatomy is. We're very good at our breast awareness and our breast care awareness, and we've started, and that health program is really, really strong. But with regard to our pelvic floor and our vulva, we're streets behind in that. But you need to know what is normal for you and what's not normal. There's age-related changes can happen in the architecture and the collagen content. We know what happens to the collagen in our faces as we age, and something very similar happens in the pelvic floor too. Our sphincter function, which controls our bowel and our bladder. We have our urethral sphincter, and there's a study shown that from the age of 35, our urethra, which is again is where our urine comes out, the striation or the strength in that urethral sphincter can reduce by as much as 2% per year from the age of 35. So really important to do your pelvic floor exercises, which I will explain in a minute. Our bladder elasticity can become altered so we can get more frequency or more urges to pass urine. And this urethral softness, your urethra again that passes from your bladder down to externally, it's important that this surface tension keeps if you imagine that's your urethra, there's a surface tension either side of it, your submucosal vascularity, and it's important that that stays moist and it stays closed as well. Yeah, for some reason I'm not going on. Oh, yeah. So some of the common symptoms that you can get are difficulty controlling your bladder and bowel. And the statistics are high for women to suffer with urinary incontinence and fecal incontinence. So it's really important that we're having this conversation. Fecal incontinence is the inability to control your bowel, so having an accident with your back passage. Urinary frequency, so that's increased trips to the toilet. Urgency to go to the toilet, so an increase in the need to go to the toilet. Stress incontinence is the involuntary leaking of urine. Vaginal prolapse, POP, pelvic organ prolapse, it's known as well. And this can be a dropping or a sensation of a lowering of some of the internal organs, and it's felt down below in the vagina. Vaginal dryness and alterations in vulvovaginal pH. Vaginal dryness is a really common symptom of the menopause, and there's management strategies for it because that can then lead in. Sometimes it can get worse. Vaginal dryness can get worse at night, and that can lead into the sleep disturbances as well. So we'll talk about it in the next slide, but vaginal moisturizers and your vaginal estrogen can be really useful for that too. Pain during intercourse is a huge barrier to intimacy with people, and with respect to that IBEX study as well, if we're talking about 50% of people having intimacy issues or interrelationship issues, really important to address that as well. And there's things that can be done, and it's really important to tell someone if it's an issue. Urinary infection, cystitis, soreness and itching associated with the vaginal dryness, and alterations of the pH and your vaginal pH. Your vagina does not need a douche. Your vagina does not need a gum that you either insert or that you eat yourself to make it smell nice. Your vagina has a perfect biome when it's left to its own devices with just being washed with water. So really and I would encourage this to stay away from your bath bombs, anything that's very scented from a soap point of view. Bath bombs, I have a friend or colleagues that calls them thrush bombs because they're so soapy and they can irritate the tissue so much. So keep it simple. Avoid anything that they're trying to sell you to make your bits down below smell nicer. You do not need them. Constipation is something that can happen during menopause as well, and it can be constipation is multifactorial. But if you're thinking of your progesterone that we mentioned earlier on in the lining of the smooth muscle, which goes around the outside of the gut, that can affect it, and also issues with the pelvic floor can too. My message is don't put up with it. If you're having any of these symptoms that are of an intimate nature, that I would say are common, 1 in 3 women will suffer with urinary incontinence, and 1 in 5 will suffer with bowel incontinence over the age of 50. Don't put up with it. Tell it to someone. This, um, from the GSM point of view, a lecture, the same lecture that I was listening to last year from Hollis Street, one of the gynecologists was saying she thinks that the international studies say that vaginal atrophy happens in menopausal women roughly 50% of the time, but she thinks in her clinical practice that it's actually closer to 75%. So from age 35, these changes can occur. I just like and have to give note to Becky Aston Physiotherapy. This is a really nice infograph as well about the GSM, vaginal dryness, the painful sex and urinary frequency, urgency and incontinence, really, and the burning and itching. Common, but there's things we can do about them. Number one in terms of management would be your pelvic floor exercises. Your pelvic floor, I've shown you where it is already on the previous slide. Your pelvic floor is a muscle just like any other muscle. If you hurt your biceps muscle, if you hurt your quads muscle, what would you do? You'd probably go to see somebody about it who would give you exercise to strengthen and train it and bring it back to its normal function. It's exactly the same with your pelvic floor. There's lots of things available online, and I think it's really important that the women's health physiotherapists, chartered physiotherapists, have increased their profile online, which is really, really good. But I think you must make sure that you're getting your information from the right source. There's a really nice app that's been delivered by the NHS, and it's called the Squeezy app, and it's evidence-based. It's by it's run by the NHS and chartered physiotherapists. So there's loads of pelvic health information on that, and it's downloadable from the App Store. But if it's evidence-based. So your pelvic floor exercises are really important. There's 2 types to do. You can do a slow hold where we would aim to hold for up to 10 seconds, and you can do a fast flicker of your pelvic floor. If you're not sure if you're doing it right, ask. I suppose the app, some of the apps and some of the women on who are prolific from a social media point of view as well that you may follow or that you may now follow, they will explain how to do them. If you're still not sure, ask your GP, and then your GP can refer. If your GP doesn't know, your GP can refer you to a pelvic health physio. There's a strong connection with hip strengthening and the pelvic floor. If our hips are strong, so if we're doing squats, if we're easily able to sit to stand from the chair, if we know that we have strong glutes, there's a strong attachment in that study by Tuttle et al. 2020 with a reduced incidence of urinary incontinence having strong hips too. That's not saying you don't do your pelvic floor exercises, but it's just important to note that too. The just in case wheeze. Now, these may be happening to you from childhood. They may not be happening to you at all. You mightn't even know what I'm talking about. They're the just in case you go into the toilet, just in case, just before you leave the house, just before you come in, just as you get into the house, just before you go out to do your shopping in Dunnes, just as you come into Tesco's, you find the toilet and you go to the toilet just in case, just before you leave on your long journey, just before you leave the service station, before you go on to the second half. We're trying to, just in case wheeze are not normal. They are a management strategy that many people bring into their lifestyle to manage their urinary symptoms. Have a read of that infograph again when this will be shared afterwards, or take the reference from it. It's really interesting to explore it. Other pelvic considerations too, and things that we can use for treatment, are vaginal moisturizers. But again, the organic types of vaginal moisturizers, it's really important that they're organic and that that they're not, that they don't smell, that they don't have an extra scent to them. Vaginal lubricant, really important, especially with painful sexual intercourse. I think we should be sort of demystifying the lubricant conversation. Instead of asking, are you using lubrication, we should be saying, what type of lubrication are you using? Trying to avoid constipation. You saw how close your back passage is to the vagina, to the urethra where your urine comes out. They're all very close. If you have a nice, healthy bowel habit where you're emptying your bowels on a relatively regular basis, it can really help with your pelvic health. Toileting advice in the next picture of slide, I'll show it to you. Your good diet is really important. HRT pessary, I've spoken about that already. HRT, the local HRT, vaginal estrogen, it can be called Vagifem, it's only locally acting. It only acts in the locality of the pelvic floor tissue. And it can be at I've lost it. Here it is. It can be in the form of the pessary. It's a tiny tablet that you put up. Generally, the prescription is you use it daily. So if you're used to using tampons and have used tampons for years, it's very easy to use daily for 2 weeks and then here on in twice a week. Bladder retraining in conjunction with your health style, with your pelvic health physiotherapist. Lifestyle, reducing caffeine and alcohol, which can be irritants for the bladder as well. I think it's worth bearing that in mind. Pelvic floor stimulation. There's a lot of talk about pelvic floor stimulation using machines. I would suggest to anybody that they have a review with the pelvic health physiotherapist before they get involved in using any piece of machinery. Supportive wear. There's all sorts of bits and pieces available on the market now to help support you if you feel you need it. And EVB leggings can be a game changer for some people running or just who would be standing for long periods a day. The impact of pelvic floor dysfunction, this to do with exercise participation. We talk about normal, we talk about common. Datchik et al. In 2021 looked at the effect of pelvic floor symptoms on women's participation in exercise. It was a large cohort study, you can see there. The results, almost half of these women that were studied had stopped exercise they had previously participated in. And the main reason for this was urinary incontinence. UI standing for urinary incontinence. So that's leaking of urine. So have a think back to I spoke about the barriers to exercise. Is urinary incontinence a barrier to exercise for you? And if it is, it's really important to know that it's common. We see from this slide, it's really common, but it's not normal. Women should not be leaking urine when they exercise. Women should be in control of their bowel and their bladders. And that's my message. Constipation. Just really what I want to talk about is the position for toileting. This talks about the position on the toilet for pregnancy. It's the same for anyone that would have a slow moving bowel. Try this at home. A footstool, often we'll have one in the house, a footstool or two turned up toilet rolls underneath each foot to raise the knees slightly higher than the level of your hips. And this has an effect on what's called your colorectal angle, and that can help with the transit. So that's another top tip to take home from this. If you're someone that has some challenges with emptying their bowels, just try this and get into the habit of the position being effective on the toilet. So what can we do, I suppose, in terms of managing the physical aspects of the menopause? Be aware that there are a myriad of them and that they don't affect everybody, and their level of effect, of how they affect us is changeable. Exercise and movement are non-negotiable, and we know that movement is medicine, so why not dip into that prescription? Your pelvic strength becomes really important, and your skeletal strength becomes really important around these years. Nutrition, important to eat enough protein and reduce your modified carbs and your sugar, and to optimize sleep, really, really important. Menopausal health. I really, really like this infograph on the left-hand side. If you talk about nutrition at the top, I know I'm running out of time, so I'll just deal with the below, which is what I've been talking about. Either your high-intensity exercise, your resistance exercise, and your pelvic floor exercises. There is a tendency for women to go to the mat in the peri and the postmenopausal years. How, if you think of your local Pilates class and the demographic of the type of woman that's going in with their mat into that class. I'm not giving out about Pilates. Pilates is a super form of exercise, but whilst there are lots of benefits of doing lower impact mat-based exercises, the benefits of doing a mixture of exercise types, including resistance and higher impact, are incredibly important for optimizing both muscle mass and bone density, which is incredibly important during our menopausal years. So variety is key with regard to exercise. Your ideal prescription, we've been through the one on the left side of what you should be aiming to do. once a week on a weekly basis, and a really nice, useful infograph on managing your pelvic floor on the right hand side. So that's just really a summary of what I've talked about during the talk. And my take home message is don't be afraid to discuss menopause. Super to be having these talks and work. Use the resources available to you and make sure that they're evidence based. Use your pelvic health physiotherapist, your GP, your gynecologist, your online resources, but with a pinch of salt. Menopause screening tools are really useful. There's the Balance Menopause Screening Tool by Louise Newsom. If you're thinking of having the conversation with your GP, that's a really nice one to have a look at first. The value of exercise in relation to bone density, muscle mass, heart health, pelvic health, and mental health. Cannot underestimate that. Current HRT, or I should have MHT written in there, is different to older preparations. Be aware of your pelvic floor and all the associated conditions and know the difference between common and normal. And if your symptoms are bothersome, please tell someone. The end.
Shirley, that's absolutely fantastic and such a wealth of knowledge and information there for all of
A
us. So
lot.
yes, no, it's absolutely brilliant. And I'm glad that you said about sharing the slides afterwards because there's
Yeah.
certainly a number
There's
there I'd like to go back on.
Yeah, there's a lot in it. And the
Yeah,
references, what I'll do actually is the references, I've referenced them all at the back, but they're not very tidy. So I might just tidy up the references before you
yeah.
share that, if that's okay.
That's absolutely
Yeah.
perfect. So if anybody would like to put any questions to Shirley now, if you just go into the chat button down at the bottom and you can put them privately to Shirley. I'm not sure if you've any there, Shirley, at the minute if they're
I
coming into
do.
you.
I'm just trying to find them at the moment.
Yeah, take your time. If you want to even come out of the slideshow.
Talk completely. Yeah.
Yeah,
Sorry now. Oh yeah,
you're okay.
lovely.
Is that easier to find them?
Um, yeah. There's a couple here, all right. Hi, just wondering in relation to bone health, for example, menopause at 45, no bad side effects, so no hormone treatment taken, now 60 and have osteopenia on calcium and vitamin D. Is there any hormone treatment that can be taken to try and slow down the decline in bone health at this age? My answer to that most definitely is with regards to hormone treatment, I'm not the expert, but your exercise, your weight bearing exercise is really important in conjunction with your calcium and vitamin D. The Irish Osteoporosis Society have lovely information on that. Also, it's still worth having at the age of 60, still worth having the conversation. There's no cut-off point with regard to with MHT. We'll talk the hormonal treatment. There's no cut-off point with regard to age with it as well. So important to have that conversation with your GP, I would say. Um, Again, right, private message. Hi Shirley, I've recently had a second ovary removed and have pain in my fingers. Is there any supplement that you would recommend? I'm not an expert on supplements. A lot of the health food stores in Kilkenny are, from a supplementation point of view. So I would say go in and have a chat with them. That's interesting with the ovary removed and the pain in the fingers with regard to the carpal tunnel syndrome as well. So maybe have a reference point, go back to that slide that I had and read a little bit more back into that study that was done with regard to the removal of the ovary and the carpal tunnel syndrome, and maybe something similar, which would be interesting. But also could be estrogen related too. Great question. Do the physical symptoms that you spoke about improve after menopause? I think it's about getting a balance. There is a study that I can't, it's not just coming to mind now, but that shows that there's a high percentage of people that really, really enjoy and embrace the postmenopausal period. And I think that's really important to remember, especially if you're going through a challenging journey at the moment. I loved Ashton's talk when she spoke to her mother, the dietitian last week, about getting the room upgrade, being in the postmenopausal space and thinking it was like going into a hotel and getting a surprise room upgrade, that things generally have improved. The quality of things, we make maybe more discerning decisions as well. That could be part of it. But generally, our physical health and our mental health and our emotional health will improve in the postmenopausal space. So yeah, that's heartening to know as well. Uh, Great information. Oh yeah, how can you tell if you're in the menopause if you've had the Mirena coil inserted for years? I'm 55. That's a really good question as well. Probably not one specifically for me, but the Mirena coil is used in from a gynecological point of view as a form of contraception, and it can be to reduce heavy periods. And in with the Mirena coil that's inserted into the neck of the uterus, it has a progesterone element. It has slow release progesterone in it. So you're already getting your slow release progesterone from it, and it can affect some of our menstrual cycle as well. So really you're going on your symptoms. It's hard to tell from a menstrual point of view exactly when that date was with the Mirena coil inserted, but you're going probably on the other symptoms that you're feeling as well. And also important when we're talking about diagnosis, I'd had a question by email yesterday about diagnosis of the menopause. The NICE guidelines, the clinical excellence guidelines of diagnosing the menopause, say that healthy women over the age of 45, the diagnosis is symptom based. So you don't need a blood test if you're relatively healthy and no other coexisting conditions over the age of 45 to manage to diagnose your symptoms. Sorry, in my what do AI and POP stand for as reasons why women don't exercise? Sorry, I should have explained them. AI is anal incontinence. Anyone who's ever had anal incontinence will never forget it. It's the involuntary leaking of stool through your back passage. POP is pelvic organ prolapse. So any downward descent of any of our pelvic organs. It can be bladder, it can be uterus or womb, or it can be the cervix into the neck of the womb, or it can be your back passage, your bowel. Did I say that? Bladder, bowel, and womb. Sorry, that was in my oh, here, is it only a blood test to determine if you're menopausal? A blood test is really only a snapshot of that time of when the blood test is taken. So it's really important to remember that when we talk about time frames, a lot of these changes have taken place over a long period of time. So you're better off to be symptom led, and the NICE guidelines say that too. Should we see a women's health physio once we turn 40 for preventative measures? And how much does obesity factor in? Obesity has been closely linked with a reduction in absorption of your topical hormonal therapy. So that's a point. Should we see a women's health physio once we turn 40? I'd love if everybody could come and see a pelvic health physio once they turn 40. I think it would be really, really useful. My physio manager would absolutely kill me for saying that because we don't have the people, the expertise in the area, and we don't have the staff. So in an ideal situation, I think it would be lovely if you could go and see a physio, but I don't think on the ground it's available from a practical point of view. Hi Shirley, just wondering about ongoing UTIs which are only respondent to antibiotics when they occur and very debilitating at work. Oh, that's awful for you. Um, any physiological conditions have been checked. Any tips in avoiding UTIs? Yeah, if you think about your pelvic health and you're reducing levels of estrogen, helps with your collagen in keeping things plump and keeping things moist. I don't really like the word moist, but our tissue is our vaginal tissue, our pelvic floor tissue loves that feeling of being plump. If our estrogen levels are reducing, often then things become a bit more dry. Things might rub against each other a bit more and get a little bit more irritated. From a UTI point of view, really important to keep your water levels high. And some people are devils for taking other liquids other than water. Sugar will really can sometimes really irritate the urethra. So keep your water levels high. The local treatment of estrogen or your vaginal moisturizers often can be a game changer with that as well, but that's a conversation for you to have with your GP as well. How am I doing for time? I'd say I'm nearly running out, am I?
You're okay. Another
Yeah,
minute or two. If you
yeah,
have more questions, Shirley,
yeah.
it's fine. Thank you.
Yeah. Does HRT help to reduce weight? Um, I don't think it is specifically affects the reduction in weight. I think what it can do is help you manage your lifestyle decisions. If you're getting good sleep and if you're exercising regularly, which HRT or manual hormonal treatment may help you to do, there's lots of studies to show that you will make better lifestyle choices. You'll make better health choices. So I don't know, I don't think specifically it'll help you to lose weight, but it may help you with the lifestyle choices that will enable you and become an enabler to you losing weight. I think that's it. Is it? I had one question that I've had time for. I had one question that was just emailed to me yesterday, which I
Yep.
think might be useful in the conversation for today. I had a forceps delivery on my third child 10 years ago, and I had no issues postnatally. I am now 45 and noticing some leaking of urine. What should I do? Now, I think this is a really um, useful question for many. Um, with the forceps, it's an instrumental delivery in terms of when you were giving birth. I'm sorry you're having those symptoms, but I suppose if you think back to the graph of the estrogen that I was talking about, during our reproductive years, our estrogen levels are high. They keep that tissue in the pelvic floor nice and plump. They keep the vascularity, the blood supply, and they keep the strength to that area. If you're hitting mid 40s, there may be a reduction in estrogen levels. So it may be that basis that you had in your mid to late 30s is depleting. So I would suggest to talk to either your GP or local pelvic health physiotherapist. The vaginal estrogen can again be a game changer for that, but it may be that you need to link in with somebody locally to manage those symptoms of urinary incontinence, because leaking of urine is urinary incontinence. And I've said it once, if not twice, if not three times, it's common, but it's not normal. If you're leaking urine, have a chat with somebody. And I think that's it. From a questions point of view, Deirdre.
Great. Well, Shirley Trimble, clinical specialist physiotherapist in pelvic health. Thank you very much for that really informative talk today.
You're welcome. Thanks. Delighted to be involved, Deirdre.